All right, so recording is on, and today we're going to start with inflammatory heart disorders. So test 3 is behind you. You probably noticed, yay. And so here we go. Now we're on the cardiac. And I pointed out to several people yesterday in reviews that one of the things, I won't say students like about test 4, but one of the things to consider is that up till now, you've had multiple topics on each exam we've given you. And while there is some population health on this one and there is some management on this one, by and large, the largest chunk of it is cardiac. So it doesn't make it easier, but certainly if you get the cardiac concepts early, and then as we move along, we build on them, it might be different and maybe a little more focused because it's more or less one topic. Okay, so let me get going. We got a lot of content. Let me let somebody in. All right, so we're going to start with inflammatory heart disorders. And it's just as it says, inflammation, right? So let's move along here. So what we're talking about in the heart primarily is infective endocarditis. It's not the only one, but it's a common, not more common than pericarditis, but it's, when we talk about heart infections, generally it's going to be this or pericarditis. So infective endocarditis, what happens? It's an infection and it's on the endocardium. Your endocardium stretches the entire inner surface of your heart, all your valves, all the inside heart muscle, all of it. So it's gotten better over the years because once World War II came and they had sulfa drugs, and then after that we've had, multiple generations of antibiotics that have been created and used and vetted and much more specific per drug than just, sulfa drugs were great when they came along. We had nothing, but they didn't hit everything. And they have such a significant component of allergy that people could die of being allergic to them. So it was helpful, but my father was a physician in World War II, and I remember him saying early in the war, they didn't have enough of anything to fight anything. And so they ended up, he would send people out to dig in garbage pails for maggots, and that's pretty much all they had for infection. So we've come an awful long way in that time. So antibiotics have certainly helped. Now, historically, it's classified as a subacute endocarditis or an acute. So what's the difference here? Subacute is you already have existing valvular disease. For some reason, you were born with it, you've had a surgery, you've had an issue develop, something has happened. So the clinical course comes on, and then it lasts for months. It's not easily resolved. It lasts. It's with you, and with you takes chronic treatment. But we know you have existing valvular disease. Maybe it's just frayed from age, whatever it is, we know there's a problem. Now, the acute one, you have healthy valves. And all of a sudden, you come in contact with some bacterial or viral or fungal pathogen. And for some reason in you, that's where it locks on. And, you now have this acute status. It comes on quickly, and it's progresses quickly, and if we don't get a hold of it, it's problematic. Now, all of them are problematic. We don't want infections of the heart. It's a dark, warm, moist environment, oxygen-rich on the left side. We don't want, it's a great environment for things to grow, and we don't need that. So we have to be very careful. Okay, let's see, other classifications. You'll see it classified as infected endocarditis related to IVDA. So the person has been using drugs intravenously, and obviously addicts don't, use clean needles. They don't care if they're clean or not when they need a fix. If you've really seen someone who's strung out, they don't care where it's coming from. And so that's a big component. They have all kinds of stuff in there. And it gets compounded with other issues they have, HIV, AIDS, other problems. I got people trying to come in here. Hold on one second. Okay. So that's another way they classify it. Fungal infections, these you're going to see in your immunosuppressed population. So you can see it with people on chemotherapy. We see it in our transplant patients. You know, they think, oh, great, I got this kidney, it's working great. I never felt so good in how many years. And now they have infective endocarditis and they're really sick, and you can have long, long problems with infective endocarditis. So everything has, you know, an up and a down, right? So the other thing they do is say it's by site of involvement. So they may say it's related to the prosthetic valve. So somebody had a bad bacterial endocarditis or a viral or a fungal, whatever they had, and it really damaged the valve to a point where they had to replace the valve. So you still have, they're treating you for this infection you have. They're trying to get hold of it. They want to make sure you're clean by multiple blood cultures before they're going to go in and say, let me try and replace that valve for you. But then they go and replace the valve and you go and get infective endocarditis again. Remember I talked back in the beginning of one of the lectures about what happens when something foreign enters the body, right? Your body's going to do whatever it can to help you. Sometimes it's not as much help as the body thinks it is, but it tries. So you're cut, or you have surgery, or you cut your finger, or step on something, cut your foot. Your body knows to send, you know, platelets and phagocytes and everything to that site. Thrombocytes make it stop bleeding, and it's sending everything. And that's nutrient rich, all of it. So a surgical site, a fresh cut, an open wound, something is perfect game for something to grow. So let's say your patient with cellulitis of the foot, you know, has a bad infection in the foot. We have them on all these antibiotics. They get an IV drug line infection. You know, this comes back to us. You have to protect your IV lines and the integrity of them significantly, because your patient can end up with infective endocarditis because somebody was sloppy. So you can't be thinking, oh, but I have no time and this and that. You can't cut corners. This is people's health. So I told you I've seen cases where someone ends up in the ICU with a terrible urosepsis from a sloppy Foley catheter insertion. Shame on us. We know there's a sterile procedure. We know this trauma victim is taxed enough physiologically. They need a sterile insertion of a Foley. And I have been in every kind of emergent trauma, running down the hall, going to the OR situation. And I tell them, in school, you're taught you need a sterile field, yay big, and you leave everything out and only touch this. I don't need it that big. I need it this much. So you're either gonna hold legs or do something or hold covers back and let me have this much sterile space, or get out of the way and I'll do it myself. But these people that'll say, oh, it doesn't matter, it's an emergency, and they just, no gloves, this and that, throw things in. Why predispose someone to that kind of infection? You know, you have 2 seconds to get this right. So now, same thing with the IV lines. And people will say, well, they're already on an antibiotic. No, drugs and bugs are specific to each other. You know, the drug they're on is not specific to whatever's in the bedclothes that you're exposing the IV to if you cross-contaminate the line. You have to have integrity. You have to know, I got to change that set out because the tubing hit the floor. You don't pick it up and say, all alcohol, it'll be fine. 70% alcohol, you know, that's not it. Change the line out. So somebody could have an IV line, they've had a prosthetic valve, they've just gotten over the, you know, they're clean from the prior episode of infective endocarditis. Now they get a line infection. It's a fresh operative site where the prosthetic valve is. It's rich in nutrients. The skin is trying to heal. It's got collagen and, you know, platelets and all kinds of things there. And that's where the bug is going to go. Once it's in the bloodstream and flies around the body, it's going to go to where there's a nutrient source. So you have to be very, very careful. Technique is everything. Okay, so what else? Causes, infection, that's what's causing it. That's what's giving you infective endocarditis. Now, Staph aureus, strep viridans, they're now the most common cause for sure. So do we see Staph aureus in the hospital? Yes, and we see a resistant strain, right? Do we see strep viridans? Sure, it's always out there. In rheumatic heart disease, which used to be a primary cause of valvular disease in this country and in the world, it's only about 20% now, because we know if we catch you early with your strep infection, and you're one of those people that's going to have an aberrant response to it and have an immune crazy situation and end up with rheumatic heart disease, then we can treat you early and hopefully get the strep under control. So we've learned a lot about strep infections over the years, and hopefully we can interfere. So we've seen the rheumatic heart disease cases drop significantly from people having staph and strep. So that's a good thing. But what are the other contributing factors? Aging is one, and that's one we can't control. Everybody ages, right? So as you get older, your valves are such delicate material with a huge job to do your entire life. But as you get older, like your skin sags more and your everything wears out more and your joints you have issues with and all these things, your valves too. And over time they can age and they don't work as well. They get a little sloppy, a little tired. Some people have calcified valves, so that's an issue too. The IV drug abusers are always, always, always at risk because they're constantly mainlining and they're bringing who knows what into the veins all the time. People with prosthetic valves, like we just talked about, and intravascular devices during hospitalizations. That's you, that's me, that's everyone who does bedside care. You have to be careful. You have an onus. It's beyond just what's easy and what seems automatic to you. You have to think of the principles behind what we're doing. Okay, so what happens? Well, blood flow with infectious agents, right? You're contaminated. Somebody contaminated your IV line or your cellulitic foot or whatever, you have an infection. It gets into your blood and it's flowing around. It's gonna look for tissue that's nutritive. One of the places is a dark, warm, moist environment inside your heart. Not always, but sometimes. So what happens? There's actual vegetation that grows. Think of the amount of blood that flows through your heart in a minute. It's volumes and volumes of blood in a day. So it's constantly getting bathed with infection. So here's a picture. Look at this picture here. Here's all your chordae. You know, your valves have these little muscles. You have chordae tendineae, okay, papillary muscles. So here they are, and they're skinny little things, a powerful job, skinny little things. And as the blood is constantly pouring through with every heartbeat, it's a good nutritive area. So the bacteria settles, and all this clumping up here is what they call vegetation. If you look at it under a microscope, it looks like little cauliflowers, little broccolis, if it was white. They tend to be like whitish, and they take on the color of blood like this. This is bathed in blood. So, but they grow like this, and it grows on the valves. It interferes with the chordae doing its work. It can interfere with papillary muscles. It surely interferes over time with the function of the valve because it doesn't belong there. It can also, you can imagine these little beady things here becoming embolic. Now this heart is obviously blown up, but because chordae, think of how big they are inside your heart. But here they are, and there's clumps of them. And even if a whole section of that were to go, this person could die with the next heartbeat, this going to the brain and just infarcting. Or it goes back through circulation wherever it gets stuck. Do you infarct your kidney? Do you infarct your spleen? Do you infarct your lung? Does it come back to the heart, get caught in your coronary circulation, and you die of a massive MI? So it drives me nuts when I'm on the floor with students and I'll say, oh, great, here's an infective endocarditis. Let's look at this case. Let's go through this. Let's see all this. And we ask the nurse something about it, and she'll say, oh, yeah, he's a nothing. He's only an infective endocarditis. And I think, how long does it take before people get to the point where they're like, endocarditis is nothing. It's not nothing. People die from endocarditis. So be very, very careful that things don't become mundane. Now think of the blood flow in your heart, right? So if there's valve trouble on the right side of the heart and you're collecting these, we don't see that much in adults, we see left side, but if you can, and if we had it on the right side and something becomes embolic, where is that emboli going to go? It goes from your right ventricle through the pulmonary artery into your lung. Okay, so you can have instant trouble in your lung. If it's on the left side of your heart, which we tend to see more on the workhorse side, if it lets go, where's it going? It can go straight up to your brain. It can go out to your kidneys, your spleen, anywhere, your limbs, you know, your distal limbs, any place. So when you have somebody with endocarditis, you're also assessing to see if they are embolic, especially if you've seen the test done in their chart that you're reading, because I'm telling you to always get into your charts, that they say vegetation noted on, testing that they've done. So you got to be looking for this. Okay, let me get back to the screen. All right, so what do you see? The problem.
Sorry, the testing for vegetation, would it be like an ultrasound or with the blood draw?
They can do echoes. We'll get into all the diagnostics, but they do culture, ultrasound, do a whole number of things, yeah. Okay, so what do you see? The problem is initially, think of the outside person, right, who doesn't know anything about infective endocarditis, and think of how non-specific the symptoms can be. When symptoms are insidious, it's so hard to zone in. So fever, okay, fever will bring somebody to a doctor, maybe if you've had it more than 24 hours. Chills usually does because they think it's bad enough to have rigor that they have to see somebody. But malaise, fatigue, anorexia, not so much. You just feel you're having an off day. Arthralgia, myalgia, depending on how bad it is. If it's arthralgia to a point where you don't want to get up and cook and eat, and it's painful to think of even going in the bathroom, then you're going to see somebody because there's some type of issue. Back, abdominal pain, probably not that much. People with abdominal pain think they have to poo. People with back pain think they pulled their back. So it's not real defining that way. But there are things we look for. And when we talk about assessing the patient, what you have to look for, these are classic things with somebody with endocarditis. Even someone who hasn't been diagnosed but is prone to it, so you can pick it up. And we'll go through each one of them. Splinter hemorrhages, petechiae, which can be for many, many things. Osler's nodes, Janeway's, Roth spots, we'll go through them. All right, so vascular symptoms, that's the first one. So this is a picture of splinter hemorrhages. And I know to blow it up on a screen like this, it gets a little blurry. But if you look at someone's hands, and it looks like they have all these, here's another one, here's one over here. And it looks like they have splinters in their nails, like down the beds. You can imagine how painful that would be. But it's not painful to them because it's not splinters. They call them splinter hemorrhages in the fingernail. It's a hemorrhage of those little tiny capillaries in the ends of your fingers, and it shows up as these little lines. So students will say to me, well, how would we pick that up? Every time I assess somebody, when you put your hands out to say, grab my hands, squeeze tight as you can, and what do? You have them push, pull, and all of that. I always turn them. I see the palms, and I turn them the other way, and I look at the nail beds. You should be looking anyway for clubbing, for cyanosis of the nail beds, right? So that's when you're going to see it. Now, this is petechiae. They always put it the plural petechiae because it never comes one petechia, People say it's like cockroaches. You see one, you see a billion. But anyway, so this is petechiae. And it's purpura kind of rash. It can be more dense than this, but it's, again, fractionated capillaries that have these little hemorrhages. And you tend to see it in areas that don't get use, like the inside of your elbows, the back of your knees. You can see it around your ankles sometimes. Some people, after having a baby, they have it on their cheeks. People, if they've had real bad vomiting, can have it on cheeks also. So it's just it's rash, but it will come like this. You'll never see one. You'll always see it like this. And it might be more dense than this, but it at least looks like this. Okay. All right, what's next? More vascular symptoms. Of course, because the issue is vascular. That's the concept. It's on the inside of the heart. It's related to the blood flow. So these are Janeway lesions. And you see these on the palms and on the soles of the feet. So again, you're doing the push-pull, squeeze my hands, all of that. I always have people show me their palms because they could have palmar erythema, tells me something about their liver. They could have Janeway lesions, tells me something about their heart. So these are very flat, and they're bigger hemorrhages than petechiae, but see how they're flat spots. This is not open to the skin. It's not that they stepped on something and it bled. This is completely closed. And it's little hemorrhages, little micro circulatory clotting things. That's what it looks like. I'm a big stickler for taking socks off. It's important to assess people's feet. And so I will say to you on rounds, when, you know, we come around and have you do a physical assessment anyway, but when I'm watching you, I expect you to take the socks off and look. There's so much we tell from people's feet. What's their circulation? Things like this, if they're prone to infective endocarditis. Do they have diabetic breakdown? Do they need someone to come and do their nails? You know, people come in with horrendous nails when they're older and no one's cut them in forever. And that's not good. Why are we sending people home like that? Those are things we need to address. So integrity of skin is very important. And so we look at the feet. But when you're doing the push on my hands like a gas pedal, pull back, this and that, you're checking cap refill. You're squeezing their toenail, checking cap refill. Look down and look at their feet. A lot is by visual inspection. And it's funny how people, I know all the people say to you, I'm freezing, and they have the hospital socks on. And I always just say to them, I know you're probably real cold. And I take the sock off and I'm going to assess your feet and I'll put it right back on again. And if they need another blanket, I get them a blanket, or I'll rub their feet if their feet are cold. But I need to see, have they had their feet washed? Has someone washed them? Have they creamed them? What's the integrity? So you kill multiple birds with one stone. All right, so these are another vascular symptom. This is osseolar nodes. So osseolar nodes are little pea-sized bumps on joints, typically your fingers. I have seen people that have them on their elbows. Even, I think I had a patient once that had a knee, more on the feet than the knee. But you see them over time, you see variants. But this is not an open scab. This looks like it's an open scab. It is not. So when you're looking at it, you look over it and you look at the etiology. Is it open or isn't it? Did they nick their finger on a drawer or something, or cut their hand somehow? Or is this an osseolar node? Big difference. So this is on the fingers and toes, and primarily, it can be other places. And it's really immune complex, clumps of immune complexes that cause this and deposit in the joints. This is a picture, well, it's a picture of the inside of your eye, and there's multiple things here. You can probably tell. The Roth spot, these are retinal hemorrhages you get from infective endocarditis. Now, we don't go looking at people's corneas, but if someone is doing an assessment or you see in the chart that the patient is positive for Roth spot, it's worth, if you have the opportunity, to get the ophthalmoscope and look. A lot of places have the light by the bed. You can see it by in the ED, in the ICUs, there's usually an ophthalmoscope. And go look at it and see. The Roth spot here is the one with the white center. This is a retinal hemorrhagic lesion. And the key is that it has a white center in the middle of it. You have, this is where your optic nerve comes out, that one. And you have your fovea centralis. So your optic disc is here. All right, let's see. Okay, so other symptoms, if they have a murmur already, it will worsen. So let's say it's the person that we know has had valvular disease and they have a murmur already, all of a sudden it's worse. And if they're inpatient, you'll hear it. Because if you've assessed them and you don't know murmurs well, and you don't have to know murmurs for this class, you don't have to know heart sounds more than S1 and S2 for this class. But if you have listened and you're used to that murmur they have, and over their time with you, they develop infective endocarditis, hopefully not, because it means it's our fault, you'll hear that they have a different murmur now. So aortic and mitral valves primarily, which is what we teach here in this class anyway, because we're talking about adults, 80% of people with aortic endocarditis will have heart failure from it. So when you hear someone say, just an IE patient in room 12, it's never just an IE patient. 80% of people with aortic involvement are going to have heart failure. 50% with mitral. And what did I tell you? Usually when you have endocarditis, it's the inside lining. So you could have aortic and mitral issues, which is significant for a patient. Your mitral and aortic valves have got to work for you to perfuse. So it's very problematic. You have to be very careful with these people. All right, so we talked about the embolization to other organs. Think about which way the blood flows. So from the right side, it's going to go to the lung. And from the left side, it goes to the brain or out to the systemic circulation. The aorta is an artery, it carries blood away. Right? Okay. What else? Diagnostics. Someone asked a great question about diagnostics. So obviously they're going to review any, recent procedures, anything you've had. Have you had a surgery that would have contaminated you? Did you have an appendectomy even? Because how does this play in? People that are having appendectomies don't clear the bowels with enemas for 2-3 days. They have a sudden appendiceal attack and they come in and they diagnose them and they run them up to the OR. So the bowel was full of stool. So now they're going in, if they can do laparoscopic, it's great. They go in and they snip closer and more confined, and hopefully they get to it before it pops and spreads stool all over the peritoneum. But that's obviously an entrance for infection if you've had that kind of surgery. Anything, gynecological surgeries, dental surgeries. There is a huge link between bacteria in the mouth and heart disease. Huge. And we didn't know it for years. I mean, you could always suspect it, the mouth is filthy. But, we're always thinking, how does it get there? How does it get there? Well, people that don't take care of their teeth, don't see a dentist every 6 months, don't go and have fillings done, have abscess teeth, don't even have an abscess tooth. They're having a root canal, and just going down into the root and cleaning it all out can expose your blood to whatever contaminants, bacteria is in your mouth. So, dental work is a big thing. Anything GI, did they do a colonoscopy? Did they do a resection? Did you have a cystoscopy? Did you have a bronchoscopy? Did you have anything, And people sometimes don't think of surgeries when you ask them as things that are done laparoscopic. So be sure you're saying no laparoscopic work, no, laparotomy for endometriosis or for gallbladder. You didn't have laparoscopic gallbladder surgery, anything like that, because they don't quite equate the same. They just think, I didn't have to have the big open surgery. So they think they didn't have it. It was a procedure more than surgery. Okay, then we look for the IV drug abuse history. That's always the prime candidate. Heart disease. Did they have surgery for their heart? Have they had stents put in? Have they had open heart surgery, a prior valve replacement? Intravascular devices, where somewhere where someone put an IV in you. And it comes back to nursing. Whoever's doing the IV care, take it seriously. Heart catheterizations, oftentimes they'll go from the groin. They can go from your wrist, but the groin is dirtier. The wrist isn't clean, believe me, skin is skin, it's dirty. But the groin, because it's pubic area and sweaty, usually just moist, hairy, it's dirty. So yes, do they scrub? They do. They scrub and prep the area and all of that, but there's always a risk. So you gotta be careful. Dialysis is another one. Now we've gotten so much better with everything disposable, but still they're accessing through the skin to get into your fistula to dialyze you. So there's always risk. Infection of any kind. Someone has a sinus infection, someone has a kidney infection, someone has a UTI, anything can cause you heart problems, anything. All right, so what do they do for diagnostics? Well, 3 blood cultures drawn over an hour from different sites. And if they're positive, that's most infective endocarditis patients. And I say most because people who have endocarditis once are prone to have it again. So, you could have a negative culture, but it's because you've been on antibiotics forever. So it's not a real reliant thing. So they keep you a long time with negative cultures on antibiotics. They take you off the antibiotics, and then they're still culturing you to see what happens. So it can be problematic. You can get somebody who's showing signs of disease, and the bug is just resistant to what we've been giving them all this time. But in most people, you will have positive blood culture results. We do 3 different locations because we don't want the same sample of blood. And it's over an hour. So we're giving the heart plenty of times to pump in an hour to get a different blood sample. Now, you hopefully will not work with a nurse who will say, we have to get blood cultures on bed 2. And you go in and they draw it out of the IV line. Don't draw blood cultures out of the IV line. I realize everyone's like, oh, great, the person has an art line. Oh, great, the person has an IV line. Oh, great, the person has a line. I can pull this off, central line. No, IV cultures are straight sticks, and they have to be in 3 separate places. And if you're the one doing it and the person has bad vasculature and you've tried and you're having a hard time, call the lab and have them come up and do it. They're a little bit better vampires sometimes because they do it all day long. But you need 3 different sites, and don't cheat and go to the IV. And it sounds like we bash nurses when we give you these examples, but we're trying to get you to see how easily it can be to get complacent if you don't keep on top of yourself. These are nurses who are good people and probably good nurses, but they're getting sloppy over time. So we don't draw from an IV line, because why? Who has an idea why it's not a good idea to draw from an IV line?
Because you have meds and stuff that go down that line as well.
Yeah, meds and stuff. Maybe there's, something down there, but how many times do we access that IV line? Probably a lot. Interrupting tubing and hanging meds and adding whatever. There's already bacteria in the hub of that catheter. There's already bacteria. And we don't need a mixed culture. We need a clean culture. So we're going to go over, and is it within an hour you have to do it? Is that 3 more times you have to stop what you're doing and come back and stick your patient? Yeah. And are you the nurse responsible? Yeah. So you know what? You're going to come back 3 times and stick your patient. And it's not always easy. And I know what it is to have Herculean things to do, a million things to do, and you have blood cultures. But you got blood cultures to do. It's one of the things on your list. And one time I'm going to take it from the hand on the left side, and one time I'll take it from the antecubital on the right side, and maybe I'll go back and do the antecubital on the left side again. 3 different places over an hour. And we know we have clean cultures. I mean, we have to get, and by clean, I don't mean not infected. I mean fresh, non-contaminated by the user. So that's important. Okay, you're going to see elevated white blood cells if it's infectious, of course. And you can mount a response, not somebody who's AIDS, not the transplant patient, not the chemo patient necessarily, but anybody else is going to have a high white count if it's bacterial. We draw CRP. C-reactive protein, it comes from your liver. And it's not specific, but it's in response to infection in the system. So, and it spikes, we see it higher than we do in ESR. Some people want a CRP and an ESR. That's fine. It's on a panel, just forget it. Lab will come up and draw your blood, not a problem. ESR is your erythrocyte sedimentation rate. And what happens when there's an inflammatory process in the body is the fibrinogen that is released in response to that will glom onto your erythrocytes. So it makes them heavier, and it makes them fall when they're spun out in a centrifuge. It makes them fall at a different rate. So the rate that they become sediment is what we're measuring here. So ESR is one. Again, it's not specific to a certain bug or infection, but it is indicative of systemic infection or inflammation. So it's one, you may see one drawn, not the other. You may see both. It doesn't matter. That's what it's for. So, and they want at least 2 of the following major criteria to diagnose it. Thank God it's not up to us. At least 2 positive blood cultures that have been 12 hours apart, which you'll find they'll order them 3 blood cultures over an hour. And then sometimes they'll wait and say 8 hours later, 10, 12 hours later, 3 more blood cultures. And then they compare them. So, you'll get in the habit of doing blood cultures, and you'll do them. Just straight stick them and do them. Non-valvular regurgitation. So this is a patient who doesn't have valvular disease, but presents with a regurgitated valve. It's not working, it's regurgitating blood. Because what are they going to suspect? That it's got something heavy on the leaves of the valve that are making it not close properly. And they're going to assume that it's vegetation. So they're going to look for that. Intracardiac mass, which typically is all your vegetation that's inside the heart that comes in clumps. Vegetation on an echo even. A TEE or a 2 or 3D echo. A TEE is a transesophageal echo. And I'll gag you, it's an endoscopy, but it goes down into the esophagus and it stops parallel to the heart, and they echo through the wall of the esophagus, through the wall of the heart, and they get a good evaluation of the heart. Believe it or not, even though it has to go through 2 walls, even for the left side, which is on the opposite side of the heart, they still get good, they're pretty cool, they get good visual, but people don't want a tube down their throat. It's like anything else in endoscopy, they consciously sedate you. So it's not like they're aware, but it is a tube down your throat. All right, we can do two.
I have,
I'm sorry.
I
Yes.
have a question. So are we not able to draw blood cultures from like an indwelling line, like a central or like a PIC or anything?
Right.
Okay.
Not for blood cultures. And
Okay.
usually nurses do it. And even if you pull the policy, it will say, don't draw it from an existing parenteral line, and they'll do it anyway. And they'll say,
Okay.
so much easier, so much easier. And I had a girl last semester in one of the units, and the nurse was doing it. And I said to the student, don't go in there and do the blood cultures. Let me find you someone who's doing blood cultures. And the nurse said to me, I don't mind if she watches me. I pull it right out of the IV. I said, that's why she's not going to watch you. And she said, I know we're not supposed to do it, but it's easy, Jane. And I thought, what do I always say? You have lost permission to speak. So we went on the other side of the same ICU. And I said, I'm always fishing for something. And I'm like, anybody got a blood culture? And they said, yeah, so-and-so's doing it. And I said, let's go in there. And he turned to her and he said, with blood cultures, you have to do it. You can't use a line and you have to do it. And took her all through the steps and showed her what he was doing. And I said to her, that's how you do blood cultures. And she said, I thought it was wrong. I remembered from class. I'm like, yikes. So, you're going to see it. Unfortunately, you're going to see it. But only you can decide the kind of nurse each one of you is going to be. And if you want to be a sloppy one that just thinks it's a job and you're going to show up every day and do what you do to get through the day, that's one kind of nurse. Hopefully it's not the kind of nurse this school has taught you to be. But you have to decide the kind of nurse you're going to be. And people are only as well off as the quality of the nurse taking care of them. I'm not diminishing the role of doctors. People wouldn't be alive without them. But the one at the bedside who has to be sharp enough to recognize something and act on it, be proactive and not always reactive, puts a patient in a better state. And there's days it's hard work. If you're doing it right, it's exhausting. It's mentally exhausting and physically draining, but it's worth it, Okay, so what other tests? They can do a chest x-ray. That's going to show us some cardiomegaly. That doesn't have to come with endocarditis, but it might. We do EKGs because think of the inside of your heart. The valves we're talking about, where are the valves attached to? All your conduction sites are there. So you'll see people will have issues with AV nodes because their valves are there, it's infected or inflamed, and it's causing them issues, and they'll start having conduction issues. So you start to put all the pieces together of how this patient is a sick patient. Cardiac caths can tell us how the valve is functioning once we're in there, and it tells us about the coronary arteries. If the patient has thrown an emboli in there and caused an infarct, or if there's, claudication, if they have a lot of atherosclerotic plaque. So the cardiac cath can tell us a lot too. Okay, so collaborative care, what's this all about? Well, we have prosthetic valves, shunts, previous history of infective endocarditis, anything like that. You put something foreign in the body, if you're exposed to systemic infection, it's going to go there. That's how people's fistulas get infected. That's how little people who have ventric drains or patients who have ventric drains from hydrocephalus, how those get infected. Everyone's like, wow, you've had that shunt in for 5 years. Where did this infection come from? Because one end is in your peritoneum, the other end is up in the ventricle of the brain, and it's all a closed system. Where did it come from? What do you think the doctor says? What have you had done recently? Have you been in the hospital where they put an IV in? Have you been to the dentist where they've done a root canal? Have you had a colonoscopy? Have you had a bronchoscopy or a gallbladder out or something? What was the portal of entry for this? So that's how that happens. I had a bad infection in my foot, or I had a tonsillitis, or I had something, went to the doctor. Could that be it? Could be. Could be. So they'll look at that. They'll do prophylactic antibiotics for anybody with a prosthetic valve, with shunts or foreign things of any kind, or if you've had a previous history. And let's say this patient is going in to have a tooth implant done, or to have a hip replacement, or to have anything like that done. They're on prophylactic antibiotics. Okay, congenital heart disease puts you at risk. You were born with these issues. You've probably had multiple surgeries before you get to adulthood. It puts you in the same category as people who are at high risk because you're constantly having something done. A heart transplant patient. Good God. I mean, we have you immunosuppressed. We did all kinds of heart surgery, and now we have you immunosuppressed, and you've had a billion lines, and post-operative, you have to come back and have biopsies. For them to do an endocardial biopsy, they're going up into your heart, threading a line and taking some tissue every time. So, and you're immunosuppressed. You couldn't fight it if you wanted. So you're very much prone to this. And this is something explained to them ahead of time. You will have to have serial endocardial biopsies done to be sure you're not rejecting. And because sometimes the hearts, the real bad rejections, they just don't knit at the sites and the person just dies, you know. But so they have to do these regular things to look for signs of rejection. Okay, invasive dental work I've spoken of. What happens is the doctor calls the dentist and they get together and say, yeah, they need to come, they need to have an extra dose. And what they do typically is give you, depending on which drug they use, they give you 4 or 5 tablets an hour before you go in for the procedure. And then 4 hours later, you take 2 more or something like that. There's some kind of, you know, there's combinations like that. And it's dose dependent. So depending on the drug they give you, it might be you take 6 tablets and then 6 afterwards. You might take 4 before and 2 afterwards, something like that. What else? Infected skin involvement. Do you have something where you have a real bad dermatitis that's infective? You know, you've had something and it's just on your skin, you're immunosuppressed, you have some issue, they're going to cover you for that because your skin is your first line of defense. And if that's infected, that extrapolates your problem. Respiratory tract things. We always look to people who have had tonsillectomies or EGDs or anything that goes in the mouth anywhere, bronchoscopies, anything like that. That's important, you know, taking biopsies, washings, anything like that. Okay, so drug therapy. Well, accurate identification of the organism is the key, which is why we want you to have good technique doing these cultures, because whatever it cultures is the bug we're going to say, well, we got to treat you for this. And if it's just you've been sloppy and it's some bug that's in the hub, the outside cap of the IV line you went in, you're getting treated for the wrong thing. Your patient's not going to get better. So accurate identification is key. There's many, many weeks of antibiotic therapy, and it can recur as soon as they take you off of all that antibiotics. And I'm telling you, we always talk about compliance. People are sick to death of being on these antibiotics, sick to death. And sometimes they get nauseous from them. By now, they probably have diarrhea. It's been weeks and weeks and weeks. So have them report their symptoms so we can give them something to prevent these symptoms. If there's another drug we can switch to, maybe they do that. But they'll have many, many, many repeat blood cultures. And if we get them off the antibiotic and do the blood culture and it's positive again, there's several things. Maybe you were on the wrong drug to begin with because someone cross-contaminated your culture. Maybe it's just non-compliance, that they're taking a pill a day instead of 2. They're supposed to take 3 a day and they take 1. You know, is it non-compliance? Or is it the wrong diagnosis? Is it that we just had the wrong, is there a fungal component? We thought it was just bacterial. Is it viral as well? And, you know, there's something else at play. And that's for doctors to figure out.
Jane, I have a question.
Yeah.
With these patients, after we draw their culture before, because I know sometimes that can take a while for the identified organism to come back, will we just start them on like a prophylactic broad spectrum antibiotic and then move to the more specific?
Yeah, usually they will. Because they don't want, if it's going to take 48 hours to grow anything on a Petri dish, they're not going to let that patient with vegetation stay like that. They're going to try and give them something.
Okay.
But, yeah. And usually by the contributing circumstances, they can kind of have an idea, you know, they can certainly figure if it's fungal rather than bacterial, you know, so they can differentiate that.
Okay.
But yeah, but as soon as they can, they will take them off to something that matches the bug they have. Because we don't want resistance we have enough of it. You know, we've come so far with antibiotics and now we're getting so resistant. So, okay, fungal endocarditis is bad. It usually has a bad ending. It's, in the end, they have to replace the valve, and that might not be the end of the road. That's not the last stop on the train here. Because if you've had that bad a fungal infection in your heart and fungi thrive in dark, warm, moist environment, then it's been really hard to kill. The drugs, the antifungals we're going to give you are real hard on the body, hard on your liver, hard on your kidney, hard on your heart, you know? So it's tough. So it's your AIDS population or your HIV, it's your transplant people, God love them, who went all through whatever they were going through with their diseases and now have that organ might be fine and they have this on top of it that's a worse issue. Or your long-term chemo people who not enough, you have this horrible cancer you're trying to fight, but now look. So it's really, fungus are really, really hard to kill. So they'll try and they'll treat you and treat you and treat you, but in the end, it can usually just reoccur. And even when they put a new prosthetic in, you can get it again because you're still immunosuppressed. If we can't restore your immune system, you have nothing to fight it with. So it's tough. All right, they'll also give them aspirin or ibuprofen or Tylenol if it helps with their vague kind of low-grade symptoms or whatever and makes them feel better. They're careful because if you're more the cardiac patient, you may be on something anticoaguling you anyway, and they don't want to add aspirin to that. Maybe they give you ibuprofen. If you are already immunosuppressed, maybe they don't want to go the ibuprofen way as much as they might go the Tylenol way. You know, it all depends on the case. All right, so what do? You are the nurse. Teach your patient, assess your patient. Think of what we do, how we can impact this person's life. So when you're assessing them, watch for this low-grade fever. Don't just take it and say, well, they didn't spike, it's low-grade. Why are they low-grade? Low-grade should mean something to you. What's the data telling you? And then go back and look. You know, well, they're 100 today. Where were they yesterday? So they were 99 yesterday and 99 the day before. What is this? You know, there's something brewing. We don't just react at 102 and above. I mean, you got to be looking. Watch for arthralgia. You know, people will tell you, well, my bones ache, but they ache on a good day. If there's someone who's older and has arthritic aches and pains, it's harder to differentiate. But murmurs, if they didn't have one before and they have one now, that's reportable, even if it sounds different to you. So for the purposes of this class, and I'll say it 100 times, you don't need to know third degree, you know, third heart sound, fourth heart sound. You don't need to know all the degrees of murmurs. That's not our field. And you're in a pre-licensure program. And so what we teach you that you learned in 101 is S1, S2. You know what that sounds like. If you're listening to someone's heart and you hear S1, S2, and then you're like, what are these other sounds? You need to go to someone who knows and say, I hear S1, S2, but I hear other things as well. And someone who, you know, usually a cardiologist, if they're rounding, I will say, perfect. That's why he's on the case or she's on the case. You know, my student needs to know what she's listening to. And don't be surprised if one doctor will say, it's more of a 3 than a 4. And someone will say, no, I think it's clearly a 4. I mean, they don't always agree either. So there's not a black and white on that. But and especially degrees of murmurs when they're trying to stage them and say they're, you know, 4s or 6s or whatever. There'll be a lot of disagreement between them on that. But anyway, so look for other things. You're assessing the patient. So look at their hands. Do they have the splinter hemorrhages? Do they have petechiae in their arms? Do they, I mean, you're having them do things, you know, push and pull. And I need to see people's skin. I need to see what they have. Endocarditis with heart failure can be threatening, life-threatening. And we don't want it to be that all of a sudden the patient's had heart failure and everyone's saying, well, where did the heart failure come from? And then we backtrack and find, oh, you know what? They had a low-grade temp all this time and they had this and that. Who missed this? You know, this is the thing. You got to pay attention to the data. There's more to the job than meets the eye, really. So what are we teaching them? Good oral hygiene is good for anybody, anybody. You admit somebody and you talk about it. You're brushing someone's teeth for them because they can't do it on their own. The trauma patients whose arms are up in slings. I always get on the subject of teeth and I'll say, how often do you see your dentist? Take every opportunity you have. We know there's a direct correlation between bugs in the mouth and people developing heart disease, even developing atherosclerosis. So it's important people get to see the dentist. And I know they don't like it. You know, nobody likes the dentist really, but the more you go, you don't have issues when you go. So it's good to go. Okay, at-risk procedures. Anytime they're having something done, if they have a previous exposure to IE. If they have bad valve disease or something, they should be following through with prophylactic care. And sometimes, I don't want to call the doctor and tell them, I'll just go and have my tooth done. It's not worth a recurrence of infected endocarditis. You know, it's not a problem for the doctor, call the office. And if you have somebody who's, you know, running the phone that isn't letting you by, they're the gatekeeper, keep pushing and pushing. I have a dentist appointment. I have to have a prophylactic antibiotic. I need a prescription. They have to comply. They have to come for their blood work, and they don't like that they get stuck multiple places and they have to keep coming and keep coming. They have to explain on whatever level is necessary for them to understand why we do this. It's not just to annoy people. I mean, we have to see what circulating bug is still there. We're trying to keep them infection-free. So exposures to infection are important, especially if it's a cut or it's something that, you know, they sliced their hand in a window, or they, you know, did something in the kitchen or something and had to have stitches. It's still an access point, and they're still at risk if they've had this before. So that's important. All right. It's 10 of. How about I give you a break and I'll see you at the top of the hour? Yeah. Let me take us. Okay, guys, I'm going to resume the videotaping. Okay, we're on. All right. So we talked about assessment and then teaching your patient. This is a big piece of what we do, right? Okay, so next up is acute pericarditis. So this is also inflammatory, but it's the pericardium. Infected endocarditis is inside the heart. This is outside the heart. So you know you have a sac on the outside of your heart, and you have a visceral and a parietal wall. It has, the visceral one is against the heart, and then the parietal one is outside against like the lungs and the rest of the chest. So what happens here is you get an infection of the sac around the heart. And the heart is usually none too happy. So we have an increase in neutrophils or whatever. We get this increased vascularity again. We get all this, everything coming to the aid of this bug that's in the heart and shouldn't be there, the fibrin, and it makes it thick and sticky. So many times it's idiopathic. And is it truly idiopathic? What they're saying is, if we've tested it, we've done procedures, we know that it's not bacterial, it's not fungal, then what is it? It's usually the non-infectious sources that we'll talk about in a minute. But it's nothing we did. It's nothing iatrogenic. It's nothing that happened related to treatment. Infectious causes can be just about anything, and you see it all. You know, virally, we're back to Coxsackie B. Remember, we've talked about that. It's a common enterovirus, probably more so in kids, but you can certainly see it in adults. An echovirus, it gives you the throwing and going and all that. It can be HIV, it could be Epstein-Barr, it can be any of those, any of the herpes group, even a varicella, something, you know, is herpes related like chickenpox, you know, it's anything. Bacterially, we see that because people get contaminated in a hospital setting. So it's the pneumococci and the staph and strep and all that. And all the gram-negative organs that you tend to get more inside a hospital than outside. That's your Pseudomonas and your Enterobacters, your Klebsiella, things like that. Now the non-infectious can be uremia. So is that idiopathic? No, because they know if you're uremic, if you've had kidney problems and you're you have azotemia, you know, your BUN and creatinine are up and you're getting uremic. They used to call it uremic poisoning. People that die in comas from kidney failure will have all that uremic frost. It's like crystallized all around. You can get those uremic crystals in the pericardium. The body has to get rid of it. It's not going out through the body. The kidney's not working. It doesn't know what to do with it, and it deposits it anywhere that'll take it. And sometimes that's uremic that's around the heart. An MI can give you pericarditis because of the inflammatory process that it starts. It's not an infectious process, it's an inflammatory process. And itis of anything is inflammation, right? So an MI can do it. Cardiac surgery can do it. Cardiac surgery can give you bacterial if we contaminate you. It can give you non-infectious. Think, we go in and we have to access the heart. We cut the pericardium open. We do what we have to do in the heart, and then we sew the pericardium up. So it gets inflamed. So you can have problems related to that. Neoplasms. Let's say you have breast cancer, God forbid, and you're getting radiation from it. The radiation doesn't stop, doesn't just go for the cells as much as we'd like to. We know the cells we're targeting, we know what we want to kill, but radiation isn't like that really. There's always something else to get there. So you're going through the mediastinum, you're going through the heart area, you're going through the pericardium, and it gets irritated from radiation. It could be chemotherapy that does it. You're getting treated for neoplasm and the chemotherapy is causing it. It could be anything like that. So dissections we'll talk about too, that if you have a dissecting vessel and whether it's on the surface of the heart or a dissecting aneurysm and blood is escaping somewhere, you're going to cause an inflammation. So it can be any number of things, but what we're doing is assessing for it. Okay, other causes. So I mentioned that post-MI, you can have pericarditis. And when it's within 24, 48, 72 hours, first couple of days after an MI, and we start seeing it, then it's related to the inflammatory response, and we kind of expect it, and it usually resolves on its own. If you have an autoimmune or hypersensitivity pericarditis, it is post-MI, but it's like 4 to 6 weeks out. It can be 8 weeks out. And all of a sudden the patient's been doing fine and home and doing cardiac rehab, and then they start getting these symptoms and whatnot. It's more so in people with rheumatic fever, because remember, someone with rheumatic fever has an aberrant response of their immune system to group A beta hemolytic strep. That's what gives them a rheumatic response. So it has to be, not everyone who gets strep is going to have rheumatic heart disease. So the fact that somebody has that factor already would make them more likely to have an autoimmune response or hypersensitivity response to an MI and have this delayed Dressler syndrome. Drug reactions can do it. So you're having a drug reaction to something, and it's almost, you're having this hypersensitive reaction to this drug. We can see it reflected in your pericardium. Any of the rheumatoid diseases, rheumatic heart disease, any of the rheumatoids, rheumatoid arthritis, anything that has an ANA factor to it, anything that's autoimmune. And again, post-heart surgery, because we cut it open and we cut open the pericardium and put it back together again. Okay, so what do you see? Well, there's severe chest pain. You'll know when someone has pericarditis. They are not happy. It's sharp and it worsens for the patient. It worsens on deep inspiration. So they'll come into the hospital saying, I don't know, I think it's pleurisy. Every time I breathe, it's killing me. I mean, they're having this horrible pain and they're associating it with the breathing. And pleurisy is respiratory related. So you will see in pleurisy that when they breathe, they get pain. With pericarditis, it's relieved by sitting them up and forward. So you're sitting them like in a tripod position. If I have someone in the ED, I'm sitting them straight up in high fallers, and I put the overbed table on and make them lean over it. And all of a sudden it feels better. Well, then try and get them to lay down to finish whatever else you have to do. They don't want to do that. But it can even radiate to their arms and all. So sometimes they come into the ED, they call the ambulance thinking they're having a heart attack, which is not, you get it. It's not a bad thing for them to surmise. You get that. They have pain maybe up to their jaw and they have it down their arms and they're scared to death it's heart attack. They probably had friends who had heart attack, maybe their parents or something. So, and they're like, it's between my shoulder blades, and it's because it's phrenic nerve irritation. So you're going to feel it up here. You get that phrenic nerve that reflects everything up to your shoulders and your back. So, that's perfectly logical. They come in that way. We do an EKG. We know they're not infarcting. Now we have to go looking for what is mimicking this MI. So they're breathing short, rapid stints because they're thinking it hurts to breathe. So they're like taking these rapid, they have dyspnea and they're rapid breathing and whatnot. And we have to calm it down. And one of the things we do, if we listen and you hear a pericardial friction rub, there's your clue. Now, pericardial friction rubs, if you're in a heart unit where people have them, somebody who has pericarditis, I would go in and ask to hear it. I bring students in rooms all the time. People don't mind. So, you have to be nice about it. And obviously, if they're in agony, it's not the time to bother them. But, they want people to learn from them. So what it sounds like is if you have two emery boards and you rub them together. That's really, it's a gritty kind of, I don't know, Lewis tells us it's high pitched. I've heard all kinds of pitches. So, you know, Lewis, we go by Lewis. She says it's high pitched, so it's high pitched for this purpose. But you'll go in there and listen to somebody and you'll say, that's funny, this isn't high pitched. Jane said it was high pitched. Not always, but that's the classification she's putting in theory. So we'll go by that. And it's usually the left sternal border. And that's where you hear it the best. And it's just like a grating. And for all the times you've listened to people, S1, S2, this is a sound you haven't heard before. So that's a classic hallmark symptom. The other thing is having the patient sit forward, up and forward, and it feels better. That helps. And the reason this helps, what's the concept here? Because your pericardium is tethered to your chest walls. And so it's inflamed and it's annoyed. And if you take you off your back where you're laying back and everything pulls and stretches this way, and we sit you forward, you don't have that added tension on this inflamed sac that's around your heart. So if that helps people, that's a big thing. The other thing is differentiate it from a pleural problem by having them hold their breath. Now they don't want to breathe, remember. They're taking these little, because they don't want to, you know, take a deep breath because it hurts. So they're thinking if I take a breath and it hurts, it's my lungs. But if they hold their breath, if it's pericarditis, every time the heartbeat, it hurts. So you have them sitting back in the bed and you tell them, just hold your breath for me. 1 minute, just hold your breath, take a deep breath and hold it. And they'll still feel it every time the heart beats. And you say, do you still have the pain? Yes. If it's pleurisy, it only hurts when they breathe. If it's pericarditis, if they hold their breath, it's still going to hurt when the heart beats. So that gives the doctor some clarity of which way they're going. Okay, so two major complications. Drives me nuts. People say, well, it's a pericarditis patient, but they were sent here and not to the ICU. So they just think right away, don't worry about them. The first one is that they get pericardial effusion. What does this mean to you? This is a fluid accumulation in the pericardium. Now your heart sits like this, and picture you have this kind of a Ziploc baggie type of thing over it, and that's your pericardium. And it's not real baggy. I mean, it's pretty snug, you know, it just holds it together. It's got a little bit of fluid in there, 10 to 15 mils maybe, all spread around so that it doesn't stick to the visceral wall, it doesn't stick to the heart. So, you know, that's what's in there normally. But now you're going to have effusion because now you have inflammation. And what happens with inflammation? The concept we keep talking about. You increase your fibrin and you increase fluid, blood goes, everything goes to try and help. So it gets like this inflamed, kind of congestive, and you get this effusion of fluid. So now it's filling up inside the sac. Now, a little bit of effusion you can probably handle. If we've decided what it is, the doctors have written orders for you to take care of it, and we can clean it up. Let's say they took a sample of the fluid in your pericardium. They say, oh, it's bacterial. We're going to give you this in a couple of days. All that inflammation is down, all that effusion is gone, and you're good. That's a good case scenario. Not that you had pericarditis. We wish you didn't, but now that you did, we can clean it up. Okay. Now, a cough, tachypnea, dyspnea, this is the compression of the lung tissue. If you go back to your anatomy and look at where your heart sits between your right and left lung, it's touching it on both sides. And everyone stays in their lane, it's fine. The lung does its thing, the heart does its thing, the sac is fine. There's not a tinge of space to be wasted. So when this effusion comes along, it's too much. It's like in the brain. We can handle brain matter, we can handle blood, we can handle cerebrospinal fluid. Anything other than that encroaching, we got a problem. So here, that little bit of compression on your lung tissue, you're not feeling it in your lung, but they have this all the time. And it's annoying them. And you'll just hear this irritation. And they're breathing faster and they have this dyspnea because they still feel every time they take a breath. Sit them forward, it helps. Okay, they can have hoarseness and hiccups. This is laryngeal nerve irritation. This is phrenic nerve irritation. Phrenic nerve is your hiccups, and that's going to happen. You know, some people get hiccups from the phrenic nerve irritation of being intubated in surgery, and they have hiccups for 24 hours afterward. Some people, it's some procedure they've done. Some people, it's this extra fluid around the heart that's just annoying the phrenic nerve for some reason. And then in your assessment of this patient, the BP is fine, but you're listening. And, you know, I always tell people, don't go through layers and layers. Person has a PJ on, they have a gown over that, they have a bathrobe on over that, and they're trying to do heart sounds. I'm like, you kind of have inhibitions in a hospital. I need to have my stethoscope on skin so I know what I'm listening to. So you're listening, and you used to hear nice, clear S1 when they came in. And now it's like you're listening through a sweater. It's muffled. It's distant to you. And that's something you'll notice, because you'll be, you know, what's happening here? Like, why is it so high? And people, nurses, I've seen them, they take the stethoscope off and they bang it. They think they have it turned the wrong way. There you go. If it's turned the right way and it seems like you can't hear it, that could be a muffled heart sound. So watch for these things. Okay, the second complication is worse. The first complication, we could still get good BP, we could still get blood flow, all of that. This is a cardiac tamponade. So the effusion gets to a point where there's so much volume inside that pericardial space that it can't fit between the pericardial sac and your heart, and it starts squeezing down on the heart. It can be acute. Let's say they're doing a cardiac cath. And when they're doing a cardiac cath, they're looking at the vessels on the surface of the heart. Yes, we can tell if your big vessels are clogged, but they go on the surface and they're looking at the surface. If when they're running a line somewhere, they extravasate and go out of that line, now there's drip, drip, drip into the pericardial sac. And if you're dripping, dripping, dripping because you're a heart patient and you've been on, you know, heparin, or you've been on continuous aspirin and all of that at home, we know that. And when they do a cath, they usually anticoagulate anyway so that you don't clot during the procedure. So you're a risk for bleed anyway, but now you're drip, drip, dripping into the pericardial sac. So that and people will say, oh yeah, the patient's back from the cath. I checked the vital signs, just make sure the weight is on the groin or the weight is on the wrist, wherever, to make sure they're not bleeding and whatnot. And they think nothing of it, not thinking there could even be issues in the pericardium. People forget what they learn, you know? So anyway, subacute can be a little more slow growing in that you've had the uremia, like the renal disease, right? Or you've had radiation therapy to your chest, and so it's causing it over time. The more radiation you get for your esophageal cancer or your breast cancer or your mets to the sternum, whatever you have, it's zapping your pericardium and causing you an issue. So that will happen more over time, whereas the acute one from any kind of procedure is filling up pretty quick. All right, so they have chest pain. Of course they do. The heart is not able to circulate enough blood. And if you're not able to fill enough, to contract enough to get it out there, you're not even circulating the vessels on the surface of the heart. Your heart at the top, where the aorta comes up out of your heart, you have these little ostia, these little holes on either side of your aorta, right in the entrance. And when your heart beats, some of that blood goes into the ostia and it feeds the circulation on the heart muscle. So if your heart isn't beating well, or you have decreased blood flow, then all those vessels on the surface of your heart are aching for oxygenated blood and you get chest pain. So this patient has chest pain. They have confusion. Why would we have a change in level of consciousness? Because you have these, on your aortic arch, you have these three stems, let's say, that go off of it, right? One is your brachiocephalic, all the way to the right, is your brachiocephalic for about this much, and then it splits to your right subclavian and your right carotid. The next one over is your left carotid, and the next one is your left subclavian. So all of a sudden, that's where your head and upper body gets the blood flow from. So all of a sudden, your heart is not filling as well because the sac around it is full of infectious fluid or effusion from cancer or bleeding from a procedure, and the heart can't beat. It's not taking blood in, it's putting less out. So if you don't have enough blood going up that aortic arch to feed your brain, your patient has a change in level of consciousness. So here's the patient with confusion, maybe some anxiety. Where's that coming from? Decreased cardiac output is going to trip your neuroendocrine hormones from your adrenal gland to say, what's happening? Do you need a faster heart rate? Do you need to break out in diaphoresis? What do you need? And so all of a sudden your patient gets all this, anxiety and all of that. Heart compression is causing the decreased atrial filling. If there's less coming in, there's less going out. You have muffled heart sounds, you have tachypnea, you have tachycardia, it's all compensatory. You have a narrow pulse pressure. You have JVD. JVD is never a good sign, no matter what it is. You have what's called a pulsus paradoxus. Nowadays, it's so easy to see this because you're in an ICU and on the monitor, you have 5 or 6 things going on that trend under each other, so you can tell. A pulsus paradoxus is a decrease in systolic BP when the patient takes a breath. So we used to actually hand do a BP and be watching respirations and see how much fluctuation there was. It was much more difficult. Now you look up on an arterial line that's giving you a continuous blood pressure readout, and you can see when the patient's breathing if that systolic BP is changing at all. But again, it's back to the patient takes a breath, there's even less room in the thorax. You've just inflated these 2 lungs. I'm already in a tight space over here, I'm gonna let less in. And then you exhale, and I go to pump out what I let in, and it's a decrease in systolic pressure because there wasn't enough blood able to get in. This patient gets sick quick and goes bad quick, real quick. All right, so what do we do for diagnostics? Well, yes,
Ms. Jane?
yeah.
Can you go over that? You said when the patient takes a breath, the diastolic pressure goes down. I'm trying to understand, I'm sorry.
Decrease in systolic blood pressure on inspiration. Because what happens when we already have a limited supply of blood, right? We have this heart, it's inside this little Ziploc bag, and blood is filling up or fluid is filling up inside from an effusion or infection, right? And it's filling up that bag and it's compressing on the heart. There's not enough room for everything. And it's a fibrous enough sac that it's not going to tear under pressure. So that's not going to be your option for release. So here it is. If the patient, maybe it can stretch this much. If the patient takes a deep breath and inflates both lungs, that puts more pressure on the sac. So what's trying to fill up in the atria is less, right? So as the patient takes a breath, that systolic BP, what came into the atria and what gets pumped out, drops. You see what I'm saying? Think about it.
Yes.
You get it? Yeah? You don't have to say you do if you don't. I can explain it again.
No. Okay.
No, you sure? Because I know it's not always easy. It's easier when you're there and you're looking at it on a screen, you can see it. But think that when someone inhales, it's decreasing your capacity. If you have a heart that normally you can do that fine. But if you have a heart that the sac around it is so full, it's hard for the heart to stretch and open up to blood and pump blood out. And then you have a patient who takes a deep breath and inflates the lungs, less blood goes into the heart. So on that inspiration, you're going to find less blood is pumping out. So you see a decrease in systolic blood pressure just when they breathe in. And then it goes back to normal. And then they take a breath again and it drops. So it's just one more indicator they have. You good?
Yes, ma'am.
No. Oh, that didn't sound too convincing.
Oh, no, no, I'm good.
You can call me after and I'll help you. Okay. All right, so diagnostics, what do we do? Okay, EKG is the most common. What you see is diffuse ST segment elevations. Now, ST segment elevation is not a good thing. You know, that's a STEMI when someone has that. But look at this picture. Here's an ST elevation right here. So if this is what you're seeing in all your leads, it's not this. This is an MI. This one is pericarditis. So they see an elevation off the baseline, but it's not high enough to be a STEMI. Also, we're going to draw labs. And your troponin is negative in a pericarditis. Your troponin is positive in an MI. So all these factors, you know, they might do an ANA, because if they don't know the source of this, they're trying to see if it's autoimmune, you know, if there's something wrong with your anti-nuclear antibodies. So you'll see diffuse changes. I tell students, I was at a conference once, it was cardiologists and nurses working in ICU and things like that. And there was this world-renowned cardiologist there, and they were talking about variances. They got into all these, you know, the weeds, they got into the weeds about ST elevations. And this world-renowned guy stood up there, and to everybody he said, look, people, when your ST elevations are significant enough that it looks like the side view of a fireman's hat, you need medic, you have an MI. And I'm looking at this man saying, of all the things he could say, that's the profound way he's getting across to all these cardiologists about stop quibbling about ST elevations. Because what he was saying is, you know, if you've ever looked at a fireman's hat, it has that plate in front. And when you look at it sideways, it's like this. You have a plate in front, and then the hat comes like this. And he said, that's significant enough. You could put a head under it. This guy's in trouble. This, you could not put a head under. That was his point. So some things, you know, he was even telling cardiologists, take it to a simpler level and stop making, you know, because they would just, you know, how to hear this conference. Well, I think it should be so many blocks up and so many blocks wide and so many this and that. And he was like, look, you got troponins besides, stop, you know, don't sweat over it. Okay, we can do Dopplers, color M mode. Color M modes is good. It tells us which way blood is flowing. So if someone has splashbacks, if the blood is flowing the wrong way for valve problems or, you know, constructive disease, whatever the problem is, it shows on there. They can do CTs, they can do MRIs and assess these things too. So there's a lot we can do. What they will do if they can is a pericardiocentesis. So they're going to go in with a needle and sample that fluid. Now, I had a student in the ICU, and they were tapping somebody for pericardiocentesis. And it wasn't our patient, but, you know, I walk in the unit, and I know so many people, and they all, you know, I said, what do you have? Something good. Where can my student come? What can they see? You know, and they said, we're going to do a pericardiocentesis. And I said, I'll see. If they're not tied up with something, I'll send them down. So I tell her, they think this guy he's had empyemic infections everywhere. He just was pussy and bug infected. And so she went down. I wanted to prepare her so she didn't get sick or something in the room. And so we went down and they tapped this guy's pericardium, and it was thick like mayonnaise. I mean, what usually the fluid pours out. It's blood or it's liquid, effusive liquid or something. And this was mayonnaise. And as if you were dumping mayonnaise from a jar, this is how it's coming out. And they're pulling on the needle, and it's thick, white, globby stuff. And the student's looking at me, and she's like, it's like mayonnaise. What is that? And I said, it's pus. And she's like, no, aren't they in that pericardium? I'm like, yes, it's pus. It's in the pericardium. I mean, gross. So you can imagine how bad this infection was. And getting it out was not easy. And then you have to worry, is it going to stick and adhere places if it's that thick, you know? So that guy was really sick. But anyway, so sometimes your pericardial centesis are just, they put the needle in and they get instant fluid out. The patient feels better. It can come right back again. You know, we're not in the clear yet, but because whatever the underlying cause is going to keep causing it unless we fix that. But at least you get a sample, you can send it to the lab, match whatever bug is in there with the drug, or if it seems like it's autoimmune, then we can take course that way. But it's interesting. If you can get in and see them, they're all kind of different, you know. Okay, so what's a collaborative care? The underlying cause is important. What is it? If it's bacterial, they're going to give you antibiotics. They'll probably give you NSAIDs to calm down the inflammation. They give you pain control if you're really having pain, not anginal pain control, not nitroglycerin or anything. They probably give you some pain control, some Toradol or some morphine if you want it, if you're that bad, depending on what the doctor orders. Corticosteroids are going to depend on the case, just like the NSAIDs. If they think you already are immunosuppressed and you're having all kinds of issues, they're not going to want to add to that probably. Sometimes they take a different turn and get you something else. It's interesting that they will often order colchicine. Now, I don't know if you remember colchicine. I think you're taught about it in renal in 152. I used to teach it, but it's for people with gout. You know, they get uremic deposits in their joint and they get gout, they get inflammation that way. And what they found kind of serendipitously years ago is that in studies with people who had gout And because they had all that uremic acid depositing, they also had pericarditis. If they treated them with colchicine for the gout, it helped the pericarditis and it didn't recur. So then they took that knowledge and extrapolated out to people with pericarditis in general. So granted, the cause is not uremia in everybody, but colchicine is an alkaloid, and the way it works is not specifically for uremia. It works on decreasing inflammation. So it has a good application here too. So just in case you get somebody with this, you'll know it's probably recurrent if they're on colchicine. But people will say, this person doesn't have gout. What are they doing on colchicine? So that's why they're on colchicine. There's a reason. All right, so here's our pericardial centesis picture. And so they do it for just effusions or effusions with tamponade, because tamponade's a problem. You're not going to survive if we don't do something. If you have purulent pericarditis, like the patient I was telling you about, or if you have a neoplasm and it just needs to be drained. It's a Band-Aid on a hemorrhage if you have a neoplasm. If you're going to continue to have radiation, or you have to continue to have the chemo that's causing this or whatever, but they can keep tapping you, or they can, put a little drain in or something and keep it open. So this is done under, they go down to specials typically. I've seen it done by the bedside with ultrasound, but at Maine, they tend to take them to specials. And so they bring you down and they'll put a needle in. Now this will be the sample that goes to the lab in the syringe here. The rest of this goes out into a container. So they're grabbing all of that. Now, and there's a little stopcock there so they can control which way it goes. Now think about this. So it's ultrasound guided, but you're taking this good gauge needle and you're sticking it through the chest wall and trying to find the pericardium, fishing a little bit, and going into the pericardium, and don't go too far because you stick that heart right here and they go into ventricular dysrhythmia. Heart doesn't like getting stuck with a needle. Don't be doing it. So they go in here and they try and get just inside, and they can feel it, they tell me, because it's a fibrous layer. And by the time they're in, it kind of punches through and they know they're there. But we're watching monitors, we're watching screens, we're watching the patient, because you could make a pericarditis even worse if you stick the heart and it starts bleeding in there, and this patient is anticoagulant and all of that, we're in a pickle. So they're very, very careful. It's done by people who do it all the time. And you have to watch afterwards because you can still have problems. I've had people come home and their lungs are popped, come home. They come back to the floor and their lungs have been popped from the procedure because they're going in between where your rib cage come up to your sternum. And so they go in with the needle and your lung lies along there. And if they're a little more left, which they usually are, they're trying to be by the apex, they can go right to the lung and pop the lung on the way in. So they get the fluid off and the patient says, I think I breathe better. By the time they're up to you on the floor, all of a sudden they're not breathing so good because the lung is popped. So, you got to watch them. Everybody needs assessing. Don't take things for granted. Okay, so procedural issues, dysrhythmias, like I told you, if they stick that heart muscle, it's none too happy, and you're going to find that you'll have dysrhythmias. Myocardial, cardiac message disease, any of that can happen. Absolutely. Pneumothorax, a continued tamponade. They can pull out, 200 mils of fluid and say, okay, patient should feel better now. That's now at 11 o'clock or whatever. 6 o'clock tonight, the patient has the same thing all over again. So then what do we do? So if they have continued tamponade, and they may even need us to give them drips and help them. I mean, they're just not circulating well and they're very symptomatic. It all depends, but we'll have to continue with procedures. So what do? They can do a pericardial window. So this is another one of those terms with all the medical terms we have in nursing and in medicine, a pericardial window. I don't know, it's weird, but all right. So what do? They go into the chest and they will take a portion of the pericardium, and it's kind of thick and fibrous, and they just open it like a flap. And this allows whatever's in there to constantly drain out of the heart, and it will go through the diaphragm, typically effuse into the peritoneal space. You can have it effuse into the lung doing this, so you got to watch this patient because you don't know how much fluid it's going to be and how problematic that's going to be for the patient, so you got to assess them. But you know, if somebody keeps getting tapped and tapped, they're not going to keep doing that. They're not going to keep sticking you every day and pulling fluid out of your pericardium. I've seen them, Lewis doesn't go into it much, but I've seen them leave the catheter in there and let it drain to a little chamber that we empty. That's, again, not a permanent fix. You can't leave them like that. But we can't have your heart fill up and cause a tamponade either, because the potential for you to die is there. So it's used for diagnosis for sure. If they think they've had a good diagnosis, you keep having recurring, you keep getting in the throes of these difficult things where your heart's not perfusing and you have all these problems, they're going to say, we have to go in and do a window and see what's going on in there. You know, what is it we're missing? And they'll do some biopsies, or they'll look around or see what the problem is. And then it just allows continuous drainage. So that's an option. All right. My cursor. All right, so what do? Assess your patient. I know I say it all the time, but you have to. Treat the pain. If they're uncomfortable, why have them sit rigid on the bed and not comply? They won't want to do anything. They don't want to move. Treat the pain. Even if it's Tylenol that's ordered, give it to them. They'll be anxious. What is this filling up in my heart? I never heard of this before. Doctor said this could be serious. What do they mean? I might have to have a procedure. I mean, they're all over the place. And if it's not them because they're stiff in the bed, afraid to move, it's the family. So explain to people. If it's your patient that's that stressed, we address people's symptoms. Don't let them stay like that. If there's something for anxiety, give it to them. If they can relax a little and feel better, it's going to help them to heal overall. So they have to engage whatever's being done with them. So make them as comfortable as possible. So the meds as ordered is important. If they want them to have NSAIDs or they put them on steroids, they may want them on steroids. Some people, depending on how immunosuppressed they are, don't want to add steroids to that. Sometimes they'll say, we got to suppress this inflammation, and they want them to have it. Some people, if it's chemotherapy or the causative agent is different, doctors feel differently about different areas. But if it's autoimmune, they may be going for that. Who knows? If it's ordered, that's fine. If that's what they want, and you have to give it. But think of other things. Think of the risk of bleeding. Think of what steroids do. Think of what NSAIDs do. Think of what aspirin does. You can't just say, oh, it's for the pericardium. You have to think, what's it doing to my patient's gut? Is it increasing the hydrogen production? Is it decreasing cell renewal? Like steroids, everything's predisposing them to bleed in the stomach, and they don't need that. So think about that. If your patient is in with pericarditis, you have to watch for effusions and tamponade. If they're a tamponade patient, then you got to prepare for further treatment. They're not going to stay like that. They'll die. So it's either they're going to have a procedure done, go off to specials, or have it done emergently in the ICU bed, or they're going to go to the OR for a pericardial window. So you always have to plan ahead to what the next thing would be. Okay, so rheumatic heart disease. Well, thank God we don't see a lot of it now. It was very big, even, I would say the numbers started dropping after the 60s, maybe 1960s, late 50s. But it was a significant problem in this country. People died of rheumatic heart disease as teenagers. They get a strep infection. No one understood that it was this aberrant response to strep, and that's it. The child will be dead before you know it, you know? So anyway, it's much better now. It is a chronic condition if you have rheumatic heart disease, and it stems from the fact that you at one point had rheumatic fever. That rheumatic fever caused scarring of your heart valves, and thank God it's less, but you'll still see it worldwide. And if you're someone who participates in mission trips, you see it in third world countries. You'll see it very prevalent other places, but not as much here. So it just speaks to you about discrepancy of healthcare worldwide. So it's an acute inflammation of the heart, and when you get rheumatic fever, and the most common cause is group A beta hemolytic strep. It's the one thing, it's the pharyngitis, it's the strep throat that people have that either they don't know they have, they think it's viral, they don't get it cultured, they don't get something for it, and your body has to have this abnormal immune response to it. Not everyone who gets strep will get rheumatic fever. So it affects the heart, it affects the skin, the joints, you get rheumatoid arthritis effects, you get rheumatoid, all the components of rheumatoid disease from it. It can affect your central nervous system. We talked about Sydenham's chorea. People can get that if it's progressive. There's much less of an incidence of it, but it's not that you won't see it. And especially you'll see it in people who have survived rheumatic fever and rheumatic heart disease and they're older because they had it before we had much treatment. All right, so what happens? Here, you have what's called a pancarditis, about 40% of the cases. And a pancarditis means they don't just have endocarditis. They have a myocarditis, the muscle layer, and they have the pericarditis with it. So this is the whole inflammatory process in the heart. It's really bad for these people. So the rheumatic endocarditis primarily involves their valves, and it's mitral and aortic in adults. That's what we see. So they get all that vegetation we talked about with endocarditis. It affects their chordae and their valve flapping and papillary muscles and all, and they become stenotic, they calcify, and they don't work well. And so they deal with it. They're identified early, usually, if they had it years ago, and then they've had the murmurs and the issues from it ever since, but it will get to a point where they really need to have them replaced. So when you see myocarditis, everything has its specific things. We've talked about endocarditis, so you know that. Myocarditis, you're generally going to see if you have someone with rheumatic heart disease. And what diagnoses this for them is these Aschoff bodies. Aschoff bodies is scar tissue. It's immune complexes, it's inflammatory response. It's all that fibrin that collects and it deposits in the myocardium. So here's your myocardium, this healthy muscle that works out all day long around the clock and we pay it no mind, is now getting full of these infiltrates of fibrin. So it doesn't let it pump very well. On top of that, they can get an inflammation on the outer layer. So they have a pericarditis, and it's both layers. It's the external layer and the internal layer. And it's got exudate, and it's terrible, and it gives them effusions, and they get adhesions from it because it's inflammatory response. And they really have a lot of damage between the valves, between the muscle damage they get. And on top of that, they develop the, arthritis from it and all the joint involvement. And really a long-term case, you'll see the Sydenham's chorea and they have trouble moving and walking. And so the key is it has to be addressed as soon as possible so we don't see people with rheumatic heart disease. All right, so 2 diagnostic factors here, 2 major, 1 minor. Or 2 major ones, or they want 1 major and 2 minor. And it's up to physicians, but just so you know in general what they're looking at. So they're looking for a heart murmur, because that's never a good thing. They're looking for enlargement, and they're looking for friction rub. It could also be the friction rub sometimes is you think you hear it, but the heart's so muffled it's hard to get it, so they'll get a Doppler or something, listen closer. It can be monoarthritis, so you have 1 joint involvement, or you can have polyarthritis. So some people have told me, patients I've had have said, I only had 1 joint involved. It was my ankle. That was the only one that was inflamed. Doesn't matter. That can be enough of a criteria for them to find it. But other people, it's every joint, their shoulders, their elbows, everything. Then Sydenham's chorea will steer them to rheumatic heart disease because that's just something so specific. The erythema marginata, this is like water-stained red rings that they get on them, on the skin when they have rheumatic fever. So you'll see that. And then they get the subcutaneous nodules. You'll see the Osler nodes. So they kind of put all of these things together. And when you see a case that's defined as rheumatic heart disease, it's interesting to talk to them and see how all these things line up. And over time, they get one and another gradually, and they can see it progress. All right, so what else? Fever, an elevated SED rate. There you go. The white blood cells are up, could be. Maybe the C-reactive protein, we talked, it's not specific, it's systemic inflammation, could be. Maybe a long PR interval. Rheumatic heart disease people have a lot of valvular issues, they have a lot of conduction issues. So all of a sudden we start seeing that. Think of where your valves are in relation to your conduction. All down that septal wall, you have conduction. and your valves are in that upper part by your AV node. So that becomes a problem. So aside from that, they'll go and do echoes and they'll do EKGs and chest x-rays. And chest x-rays usually just tell you the heart's a little enlarged, especially in this kind of inflammatory process. An echo can tell them more about the valvular function, how evenly the blood is flowing, and how the valve is moving. They can see that on an echo. The EKG is going to tell them, are you starting to see prolonged PR intervals, any kind of conduction blocks, you know? So they do the SED rates, they'll draw a CRP. They also draw an ASO. An ASO is your anti-streptolysin titer. If this is positive, you are still active for strep. So if you have a positive ASO, they're going to give you something to treat your strep infection, because as long as you have it, it's going to keep doing you damage. Or you already have rheumatic heart disease, and then they're just checking you out and they draw an ASO because you're complaining of who knows what, you have a sore throat or rhinitis or whatever, and they draw an ASO and you're positive. They'll say you have another strep infection, and they're going to treat you for it because it's just going to continue to cause you damage. Yeah. Okay. What else? Collaborative care. So the thing is, we're trying to match a bug with a drug. So if they find that your group A hemolytic, beta hemolytic strep is positive, then they want to get rid of it. So they can give you, you know, your PenVK or moxicillin, any of them, you know, lincosamides work. They could give you a clindamycin. The macrolides are okay. They give you azithromycin. I mean, it all depends on what they're matching your culture to. And maybe steroids, NSAIDs, salicylates. Again, you have to stop and look and say, in my patient's overall care, I know they automatically order this when they order, you know, treatment of this condition, but what's my patient at risk for? What are we doing to protect the GI if we're giving them steroids and or NSAIDs, which decrease your prostaglandins? Those are protective to your GI. Salicylates, that's your aspirin. It's antiplatelet aggregator, it's increasing hydrogen. You got to think of what it does to the lining of your stomach. So your patient is at risk for a GI bleed. You got to watch, okay? All right, so is that, what do you do? Nursing goals. If rheumatic heart disease is present, you have to manage the organism. So they will order something. We're going to look to relieve whatever pain they have if they have some. It's usually achy kind of pain. Prevent the complications and teach people early strep detection. If you've had any kind of infective endocarditis or pericarditis or anything, when you think you're sick, you have to get cultured, because we can't let you have something that's going to continue to exacerbate the problem. Treatment with antibiotics and teach compliance. You know they're going to get, even you, if you have a antibiotic for 8 days for anything, you know, pharyngitis or I don't know, anything you have. People don't like it after a couple of days. If you're supposed to take it with food and they don't, then they're nauseous. If they take it and now it's eating their gut flora, now they have diarrhea. So don't sit there and suffer. You get something to restore, you get Florastor or something that's going to restore your gut. So the same thing in the hospital. We're going to ask the doctor for something. Patient's having diarrhea after so many days on clindamycin. What can we give her? And get something for it. Let's mitigate the symptoms related to this treatment rather than have them give up the treatment. They don't understand the danger of them not taking, when they feel better, of them not taking their antibiotic. You do. So you have to impart on them how they have to be compliant. And there's more than one way to get around it. Let's see what makes it more palatable to you. Promote rest. They have to heal. We get them up and moving, but with active myocarditis and endocarditis with all this vegetation, the doctor may restrict a lot of that workload and a lot of effort and heavy moving and this and that. Meds as ordered. Their joints will hurt them with rheumatic heart disease, so they really don't want to do a lot, so we do what's comfortable. It's not that they might get range of motion, we'll probably do that, but do they need heat to their joints? Do they need elevation? I mean, what is it? And give them what analgesic we have. Even sometimes patients will say to you, I don't ever take Tylenol. I really don't ever take, try it. maybe you don't need it, but it is a good analgesic. So maybe prior to this, you don't need it, or you didn't think it helped with whatever you took it for. It might help you now. It's worth a shot. You know, we're seeking comfort so people aren't miserable. When they're miserable, they won't eat, they won't sleep, they won't comply. You got to get them feeling better. And it doesn't take much. You know, assess what you're looking at and what can you do to relieve the symptoms. Okay? All right. So go have your lunch and I'll see you back here and we'll do valves. Okay? Any questions? No?
Ms. Jane, you did say do range of motion even though they're on rest, right?
Some doctors